Uh, Dear pure urology viewers, good evening one and all. The today topic is enucleation of the prostate, anatomical enucleation of the prostate. The speaker is Dr. Dheeraj Kasaraneni. He is from Vijayawada. I know about him in detail. He is actually a son of a very well-known urologist of Vijayawada, Dr. Prashant sir. As you all know, son may not be recognized as the son of so-and-so, but the truth is you will be recognized in the initial part as son of so-and-so. But Dheeraj unusually in the short period of time from Vijayawada, because he belongs to our Telugu state in Andhra Pradesh and Telangana, he concentrated on the endourology, more so on the enucleation of the prostate from beginning. So sooner, in 1 year, 2 years, he has become known enucleation specialist, and probably in the future also I wish he will become enucleation specialist in the India as well as the world. So first I will ask him few questions. Dheeraj, thank you for accepting the invitation, and hi.
Thank you, sir. It's a great privilege for me to be part of this pure urology group, sir. Thank you for having me in this talks.
Your father is urologist and you are urologist, and your brother is also urologist. What is your brother name?
His name is Dr. Preetham, sir. He has done his uro-oncology fellowship recently.
Okay. So father is Dr. Prashant sir, who has done MCH from which place?
From Bangalore, sir. From Victoria Hospital, he has done it.
Victoria Hospital. You did your MCH from?
Ramaya Medical College in Bangalore, sir.
Ramaya Medical College. Yeah, recently you have come there. And who did, your brother did where MCH urology?
He has also done from Ramaya Medical College after he left the institute. He has done there for 3 years, and he has gone to Delhi for Rajiv Gandhi Cancer Institute.
Okay, nice. So, what did any part of life your father forced you to become both of you urologists, or you liked and became? Silly question, but take it easy.
I can answer for my part, sir. I'm thoroughly interested in surgery. Then I had 3 options of gastroenterology, urology, and oncology. But I thought to build upon something which is already there, a platform which is there, I thought urology is the best thing for me to grow upon it.
Yeah. How many bedded hospital your hospital is?
Ours is a 50-bedded exclusive urology setup, sir.
I think it's time to apply for DNB and with expansion.
We are planning, sir. We're planning in the future.
Very good. So I will introduce the Dheeraj officially, and then I will hand over the program. So dear viewers, our idea of introducing the speakers is, some are motivating. See, we all feel that our children should become doctors, surgeons, specialists, same branch. It's a dream for any father to have 2 sons urologists, and both of them excelling in certain fields of the urology is a welcome sign. So with this, I say that anatomical enucleation of prostate with thulium laser, thulium fiber laser as well as thulium laser, both he will say a little bit, because this will be a unique talk in that way. Dr. Dheeraj Kasaraneni, he is consultant and advanced laparoscopy and endourologist in Prashant Hospital, Vijayawada, Andhra Pradesh. Lead consultant urologist for Ramesh Hospitals and honorary consultant urologist in Government Siddhartha General Hospital, Vijayawada. Awarded the best outgoing postgraduate in MS and MCH. Areas of interest in minimally invasive endourology, laparoscopy and transplantation. Succeeded in achieving hands-on individual experience by doing more than 2000 odd PCNLs, 1800 odd RIRS, 500 odd laser enucleations and 250 renal transplants using thulium YAG 200 watts since 2016. Now he is also using TFL since 2018 October. Invited operating faculty for RIRS and en bloc enucleation. So as I mentioned, he is concentrating on his work, and hope he will do better in the future. So with this introduction, I also wanted to ask you quickly before you start, do you think the mechanism ultimately delivered on the screen appears the same, even though they are totally different? Thulium fiber laser and thulium laser, both of them produce a certain amount of coagulation, certain amount of charring, excellent hemostasis, easy to learn. Both have something common. Do you agree with me or not?
A lot of it is common, sir. When you compare the holmium laser with this, both the thulium lasers, be it YAG or the TFL, both have very similar properties. Also, their wavelengths are also very similar, which is very close absorption to the water. Hence, the hemostasis and water properties we are seeing on the screen is very similar, actually.
Yeah. So what happened with me is that I am not experienced in thulium laser. I am not experienced in holmium laser. After the thulium fiber laser, even in 2018, when I have taken 60 watts, I realized that enucleation can be done. Then I started, and after that, Dr. Manas, who is a co-host today with us, is also part of the Preeti Hospital consultant, who, like you, has focused on this surgery and got some knack in that surgery and progressed. Maybe he is more experienced than me in understanding the enucleation of the prostate, especially in the middle part of the lobe and the bladder neck region. So I request Dr. Manas also to interact, if not as a senior, as your colleague, and both of you interact properly so that surgical technique part, let the youngsters who are buying 60 watts thulium fiber laser do it more and more so that it will be useful to them, they will learn. So thank you. With this, I will hand over the program to Dheeraj as well as Manas Babu. Manas, thank you for coming and for the invitation.
Thank you, sir.
Yeah, please. Over to you, Dheeraj. Please proceed.
Manas, can I start my slides?
Yes, Dheeraj. Stage is yours now.
Yeah, this topic is, I'm going to talk about the anatomical enucleation of prostate with both the thulium and the thulium fiber laser. So there's no conflict of interest except that I have started doing thulium laser in the 2019 and 2020, and also started doing the TFL enucleation at around 2020 and 2021. I'll talk about how I overcame the initial hurdle of a big learning curve, which is usually there for the enucleation of prostate, and how thulium laser helped me in overcoming the learning curve, and how I evolved from the classic 3-lobe technique, which I was doing, to the unblock technique, which I do of late. And also, I'm going to highlight upon the mini instruments, the 22 French resectoscope, which I have been using since the last 9 months. I'll show you all the instruments and the equipment which we use, and also describe in detail a procedure video of overcoming the challenging scenarios during the enucleation surgery. And if you have more time, I'm going to show you about what is the difference between a thulium YAG laser and what a TFL laser can do, and also show the difference between using more of laser energy and also more of mechanical dissection. If you have more time, I'll also show some of the advanced Thulium procedures which we have done. As you all know, I'll quickly run through the background. As you all know, the European Association of Urology guidelines state that patients on anticoagulants and very large glands, there is an indication of doing enucleation. The recent AUA guidelines state that the holmium and the thulium laser are size independent option. They also recommend them as being used for the smaller prostates as well. I feel that enucleation of prostate has the advantage of giving the maximum efficacy with regards to the best urine flow, and with the reduction in the symptoms, and with low morbidity when you see the hemostasis and early recovery of the patient. However, the disadvantage why many people are not doing the enucleation is because of the long learning curve, and also the expensive technology when you look at the laser machine, also the morcellator which we need. And the biggest hurdle, even though if you have this learning, if you have already learned the enucleation and also have the equipment, the main problem is the stress urinary incontinence, which I'll highlight upon how to avoid stress incontinence during the procedures. So there are different energy sources. I am well versed with the thulium, the pulse thulium laser, and also the thulium fiber laser. It's not at the end of the talk, my takeaway point would be that it's not the energy source which is important. It's how you use the energy source, and whether you thoroughly know whatever laser machine you are using is important. And also the technique of enucleation, whether it's the classic 3-lobe, 2-lobe, or the 1-lobe, early apical or the late apical liberation, all the techniques we need to learn, because the prostate morphology is not the same. There will be small prostates, big prostates, different. The morphology of prostate is so different. We might need to use either of these different approaches for different prostates. So we have to go with an open mind when we are going to perform an enucleation of prostate surgery. We had this laser thulium YAG laser since the 2016, but it was until the 2018 I have not started properly doing it because of the learning curve. Initially, I was using the vaporization technique because thulium YAG laser is very The wavelength is very similar to that of the water. The absorption is so good and the hemostasis is very good. So initially I was doing this vaporization technique. For all the beginners, it's a good technique because to get the hang out of the laser, we'll have to start with the vaporization. You touch the prostate tissue with the laser fiber and you activate the laser, the prostate tissue gets vaporized, ablated, and later gets vaporized. This is the beginning of how I used to do my prostate surgery. But the results were not good because a lot of tissue was getting remained, and because of the charring, patients were having a lot of dysuria. So later on, I've switched over to the resection, the thulium vapor resection. If you can see an example here, I'm resecting the prostate tissue bit by bit. If you can see it, just like a TURP where we resect the tissue from the proximal to the distal region, I'm resecting the tissue from the distal to the proximal part. This is occasionally useful for me in a dense prostate where any tissue is left behind. I still use this technique to remove the tissue. So after vaporization, my learning curve, I was vapor resecting the prostate. Later on, I went to Dr. Ramesh Ramaya in Pramila Hospital, and I learned the technique of vapor enucleation. This is the median lobe here. What we do is we do more of laser energy. We use more of laser energy, and this is not an anatomical plane. Anatomical plane is always finding the capsule. This is not finding the anatomical plane, but we are only are enucleating the prostate by burning it and enucleating it. That is called the vapor enucleation. This is not the anatomical enucleation which I will be describing. However, in the beginning of the learning curve, when we are not able to find the proper anatomical landmarks, unlike holmium laser, thulium laser helps us to at least finish the procedure without converting it into a TURP procedure. This is the median lobe which is done, and this is the lateral lobe where we give a 12 o'clock incision and deepen it, and we are going to join the 12 o'clock incision to the 6 o'clock, and we are going to remove both the lateral lobes.
Dheeraj,
Yes. Manas, I couldn't hear you.
Dheeraj, can you listen me now?
Yeah.
Dheeraj, what is the main difference you notice between vaporization and vapor enucleation? And what is the patient perspective?
Vaporization is the initially when I used to do for my initial 10 cases, I found out that at least 3 or 4 patients couldn't, there was not much significant improvement in the uroflow rates. I was very unhappy with the results. But the thing I would recommend is for anybody who's starting the laser enucleation, just start with the vaporization, get the hang out of the laser. And ultimately you need to either vapor enucleate or find the anatomical planes, and then you need to do an anatomical enucleation. So initially, to overcome the learning curve, it's very hard to find the anatomical planes even in the initial cases. So vapor enucleation is a good thing for the beginners to understand. And regarding a misconception everybody has is that thulium laser, everybody thinks is the continuous laser. But I'll show you the setting in our machine. You can see that there's a continuous setting where the wattage can be increased from 0 to 200. 200 is really helpful in the vaporization to do a fast vaporization. The people don't realize that thulium YAG laser also has the pulsed mode. If you can see here, when I'm going here to the pulsed mode, I can have the short pulse, I can have the long pulse as well. Short pulse helps in the better cutting and better developing of the anatomical planes. And I use a frequency of about 50 or 100 routinely. So I'm able to generate about 87 watts of pulsed energy for the laser enucleation. These are the settings which I use for the continuous wave, and these are the settings which I use for the pulsed wave. If you can look here, this is very similar to the 35 watt thulium YAG laser. Here the pulse, the wattage which is generated by this mode 5 short pulsed 50 hertz mode is 38 watts, which is very similar to the pulsed TFL laser, which is 85 watts. And on the other hand, if I use the pulse of 100 hertz, it's very similar to the 65 watt TFL laser. I had a chat with Dr. Gilling in World Congress of Urology in Paris, and he says that without finding the anatomical planes, without finding the anatomical plane of the capsule, you are never going to completely enucleate the prostate lobes, which is when later I started this THULEP. This is not THUWEP, this is THULEP. THULEP is pushing the lobe, finding the capsular plane, and then applying energy to cut the lobe. This is the THULEP. This is completely different from the thulium vaporization, where you don't need to see the capsule, but continuously apply energy and follow the morphology of the prostate and enucleate it. But this is finding the anatomical plane and proceeding by gentle pushing, developing the plane and applying the energy. So then one day, Vamsi sir from Hyderabad, he has come down to my hospital where we piled up 4 cases and helped me develop my technique. He has suggested that we can use this pulsed wave energy also in my machine. And I started using this pulsed wave, and I have never had to look back. I never went to the continuous mode. If you can see here, this property is very similar to the TFL laser which we are using. What this does is I don't do the contact mode. I just come 1 to 2 mm away from the tissue and fire the laser. What it does is it produces the bubbles just like a holmium laser, and we are able to get this holmium effect. Now this is very similar to the thulium fiber laser which we normally use. And thulium fiber laser, although I didn't buy it for the purpose of enucleation, for the stones we have bought it, and because the equipment malfunctioned, this 200 watt thulium yak laser malfunctioned, I had to use this laser for one very important patient, and I was able to complete 250 gram prostate enucleation in a single go. Then that's when I realized it's not the energy which we are using is important, the way which we use is important. Thulium fiber laser, the difference is that it has a diode laser energy with thulium doped ions. It's not the thulium generator which is there. It's not equal to the thulium YAG laser. Professor Thomas Herman is the one who inspired me that it's not the laser energy which we use, it's the technique which we have to develop, and we should know what energy source, how to use it. That's his philosophy which inspired me. And the main problem which we have when we start enucleation is 2 main problems which we had initially, which was when we had these problems, we used to stop doing enucleations for a while and come back to TURPs because of 2 dreaded complications. One is the early stress in urinary incontinence. The other one is stricture urethra. 2 things which helped me is Fernando Gomez Sanchez's philosophy of early apical release with the en bloc technique. And after trying to apply this technique in the procedures, I found it very useful, and I found that the stress in urinary incontinence reduced, and it gave me confidence to further continue the procedures for more complex cases. And enucleation, I feel, is the pinnacle of BPH treatment, unlike the classical technique where we give more incisions, and I feel more time is required to do the classic 3-lobe technique. And the advantage of en bloc technique is that it has a faster operative time, and also it is a very reproducible technique. The other influence which I had in the recent times is the use of this 22 French resectoscope, which I have been doing since the last 1 year, and I found it to have good results with regards to having less stricture formation. And it's not only about the stricture. I'm able to go into the narrow spaces as well, and I'm able to perform my enucleation in a more effective manner. These are the instruments which I normally use.
Dheeraj. Hello, Dheeraj.
Yes.
Yeah. Dheeraj, did you notice really these small size scopes really helps you during 2-lobe or 3-lobe, traditional 3-lobe technique, or only it is useful only when you are doing en bloc technique?
The thing is, Manas, before I started using these instruments, I already switched over to my en bloc technique, because en bloc technique I have been doing since the last 1.5 years. I never tried doing this 3-lobe because I'm very comfortable doing the en bloc, and I feel that if you are doing en bloc only, then probably you can use these instruments, because when we are doing this 3-lobe technique, we need more of irrigation. Irrigation should be adequate. So the advantage of en bloc technique is that we are working in a very close space, and to use this 22 French, the irrigation, whatever it generates, is adequate for us when we are doing this en bloc. Probably the 3-lobe, I'm not sure it will help as much.
Yeah. So basically to say that when you are doing the en bloc only, then this mini left ultra slim is useful. When you're doing a traditional 2-lobe or 3-lobe technique, it doesn't do much difference.
I have not tried it, but I have to see further. I have to try it and see further.
And also, when you're doing the 24 French or 26 French, did you really notice there is a significant stricture rate while you're using the enucleation with laser?
Yeah, I've heard many enucleation surgeons say that there are no strictures, but whenever I had strictures, they were very tight strictures and long segment strictures whenever I had them. One observation I have done was when I do these enucleations for smaller prostates like a 40 gram, 50 gram, 60 gram, that's when I find the urethra, posterior part of the urethra very narrow, and that's when I had more strictures than when I had done enucleation for the larger glands. I also believe that when there is a larger gland, there is a larger caliber urethra as well. That's my observation. I don't know about the other surgeons, but that's my personal observation.
And you told that when you do the smaller size gland, you had noticed the strictures. That's mainly bulbar strictures or in the bladder neck stenosis thing?
Bladder neck stenosis, initially when I was using this vapor enucleation technique, when I was using more energy at the bladder neck, I had this bladder neck stenosis. At least 5 cases I had initially, but I've stopped using high energy at the bladder neck, and now I'm going to show the technique of bladder neck sparing as well, where we can prevent all these bladder neck contractures.
Yes. Go on. Thank you.
So the advantage of this 22 French sheath is that we can directly go without any obturator. We can put this camera, we can put this slide source, and just like a Foley's catheter, you introduce the resectoscope into the urethra as well. So this is my OT setup. You'll have to have everything in place. I usually use the IPGTF laser or the twin MEAC laser. I use the Wolf Piranha morcellator, and always have an ultrasound standby because any bleeding is there. Probably the vision won't be good during morcellation. So the ultrasound also is a must. One luxury at least I have in my hospital is I use the 4K camera system, which really over the last 1 year reduced my learning curve, I believe. I think it's not a compulsion, but it has really helped me to shorten the learning curve as well. This is my typical OT setup where I have this IPG and the Piranha morcellator. And also I always have a ultrasound here so that by the end of the enucleation, I'm already tired, and to do the morcellation, I believe that the bladder injuries during morcellation is only because of lapse of concentration. And if you have an ultrasound guided morcellation done along with seeing into the monitor, it has the extra advantage. And I feel the bladder injuries also comes down during morcellation. So always it's good idea to have the monopolar and the bipolar also standby. But luckily for me, in the last 2 years, I never had to use the monopolar or the bipolar to control the bleeding. A laser alone was enough for me to handle the bleeding. But always, if you have any doubt whether it's always good to get your resectoscope and control the bleeding as well with the monopolar or bipolar cartridge. So there'll be a lot of challenges.
Dheeraj, just a minute. About the use of ultrasound during the morcellation.
Yeah.
Yes, Vamshi sir is one who pioneered that thing.
Yeah, he introduced it to me actually. Yes.
Yeah. Just I wanted to know, while doing morcellation, when the vision is not good, while doing morcellation, your eye will be on the ultrasound screen, or your eye will be on the endo vision.
If the vision is not good, if I'm not able to see the prostate properly during morcellation, I'm more comfortable looking at the ultrasound monitor than the
only seeing ultrasound monitor, and you do.
Only thing is only seeing the ultrasound monitor, and my staff are well trained to show me the prostate in the axial plane, also the vertical plane also. So I know also the depth at which I'm holding the tissue while morcellating.
We never tried.
I'm very comfortable with ultrasound guided morcellation.
We never tried it, but the idea is very good. We have to try it.
Yeah. I'll show you one of the video also if I have time. So these are all the challenges which we have. The small caliber urethra I already addressed. By using the smaller scope, we can reduce the stricture. And this is one case where a few cases will encounter where we'll have a rigid pelvis and patient has to be placed in extreme lithotomy positions. And sometimes we need to do a perineal urethrostomy as well and do the enucleations. In that scenario, the lithotomy rods which can be adjusted by you during the surgery also helps, because we need a lot of freedom of movement for enucleation, especially when doing the large glands. We need to do extreme movements, and these special lithotomy rods always are helpful. And the most important complication of enucleation is the urinary incontinence, which I believe is more often because of urge incontinence rather than the stress incontinence. Of course, there are reasons like age, general health, past history of neurological disease, and also bladder dysfunction, which are the factors for urinary incontinence. But having a thorough knowledge of the anatomy, we can prevent this stress incontinence by proper technique. If you can see here, the sphincter here is coming into the prostatic apex. This is the prostatic apical tissue, and you can see that the urethral sphincter is coming into the prostate. And also, if you can see here, a good part of the functional urethra also is occupied by the prostate. Manas, if you can see, I'll show you a small diagram here. And this is a Fernando Gomez Sancha technique where we give an incision just at the verumontanum and we try to go here. Many people try to find a capsule here, but I think in this process we are stretching the sphincter region also, and we are causing more harm. Proper anatomical enucleation, I feel we have to go this way. We have to find the right plane. I call this the corner of the prostate. I'll show you during the video. I'll call this the corner of the prostate. Only if you are able to go to the corner of the prostate without stretching the tissue, you are going into the nice anatomical plane. So if you see the shape of the prostate also, you can see here the striated sphincter, it is more proximal when you compare it with the posterior aspect. And one more thing,
it's like a horseshoe shape, right?
Horseshoe shape, more towards
so that most of the sphincter, majority of the sphincter will be mainly on the anterior part. It will be deficient on the posterior part, so that it will, well, finding the correct enucleation place easier to find at the mainly at the 5 and 7 o'clock position, right? Am I right?
Yes, correct. The idea of preserving the ventral mucosa also is because of that only.
Yes.
Apart from preserving the ventral mucosa, I believe if you are able to maintain nicely preserve the urethral mucosa, it helps in the early continence. Much of the studies, like when patients post-menopausal women, they have urine leak, and also stricture patients have urine leak. It is only because there is no proper coaptation of the urethra. And also I believe if there is a proper preservation of the ventral mucosa, we'll have this early continence. So, and the other thing about the early apical release technique is that we are not very sure where exactly the 12 o'clock position is. Although there is a verumontanum, it's not necessarily always at the 12 o'clock we find the distal most limit. We are almost the prostate apex comes distal to the 12 o'clock position as well, just above the verumontanum. So for this, we have there's a different technique. There's another technique introduced by Sion from Seoul, who has developed this inverted V-shape incision. The basis of this technique.
Dr. Home.
Sion Home. From Seoul, yes. So what he has done is he has first he will develop this posterior plane by forming bilateral mucosal wings at the apical prostate. And what he'll do is he'll mark an initial 12 o'clock incision, and he will give a V-shaped incision connecting the 12 o'clock incision to the apical wings, which has already formed. And he will deepen this incision and try to find the mucosal plane. This is the Sphincter-saving technique, which I'm very fond of. And this is one of the picture. Here we are going to develop the posterior surgical plane initially after marking the 12 o'clock incision. And after that, we'll join this 12 o'clock incision to the mucosal wing here, which I'm going to show you in this video. In this process, we are going to nicely preserve the ventral anterior mucosa, and which is really helpful in the early stress incontinence. This is one of the video where I've done a Thulium YAG sphincter-saving technique. This is a short video. If you can see here, it's very difficult for me to reach the bladder because of the high median lobe. The procedure starts by marking the initial 12 o'clock incision, 11 to 12. And what I do is I use gentle mechanical force to develop a posterior surgical plane here. I rarely use energy here. I mostly use the beak of my scope and use the gentle mechanical energy to develop this posterior surgical plane.
Is it beak? Is it beak only of the Carl Starch type of this thing, or you have any specific beak for this, Dheeraj?
The regular beaks. Previously,
regular beak only.
Carl Starch. But whatever videos I'm showing, these are from the last 1 year, sir. Everything was done with a mini. With a 22 inch.
By doing this mechanical, you'll nicely peel off, and intermittently you can use the laser. Does it affect the sphincter function if you do especially large gland roughly?
Posterior surgical plane, if you do, it's okay, sir. But if it is a large gland, I'm going to release this sphincter early. I'm going to use mechanical energy only if when I made sure the apical part of the gland is completely free of the ventral mucosa.
Okay.
Only then I'm going to use the mechanical energy. Before that, I'm not going to use except for this development of the posterior.
Okay.
So this posterior plane here is nicely developed. In that process, we are developing mucosal wings on either side. If you can see here, this is a mucosal wing here on the left side. Now what we are going to do is we are going to give an incision. on either side. This is the inverted V-shaped incision. Once I give this incision, I deepen it further and try to remove as much of apical tissue as possible. Only after I do that, I'm going to use gentle mechanical energy here in the posterior apical plane on either side. And after that, I'm going to use little of laser energy towards the 10 o'clock to the 2 o'clock position. If you can see here, only the ventral mucosa is attached finally between the 10 o'clock and the 2 o'clock region. That's when I use little laser energy to completely remove the apical attachments, which is attaching the ventral mucosa. So this is the sphincter-saving technique, which I developed, and it has given me a very good results, and my incontinence rates have really come down. I'm really motivated to do even complex cases after I started using this technique. This is done with, if you can see, with the Thulium YAG laser in a pulsed mode. This is not a continuous mode. This is a pulsed mode which I'm doing, and the energy which I'm using is very similar to that of the 35-watt Thulium YAG laser. So that was about the sphincter-saving technique, and I'm going to show you, because many people are using the TFL laser of late because they already have it for the RIRS. I thought I'll demonstrate in detail about the laser of TFL. 35 watts, which I have done. So these will be the surgical steps. I'll develop the posterior surgical plane first, followed by the apical dissection. Once the apical dissection is done, I'll join the anterior and the posterior planes. After that, I'll enter the bladder to the anterior region, and I'll finish the lateral lobes and the posterior dissection in the last. Manas, you can stop me at any time during the video.
Yeah, so, man. No problem. You continue.
So this is the 12 o'clock incision I made. If I'm in any doubt, I give the incision little proximal.
Yes,
if I have any doubt, I'll give it as proximal as possible. No harm in little.
Dheeraj, can you please pause the video here? Just it's one of the important steps. Everyone needs to know about this. So, what is your correct exact landmark? Because anyhow, we will go near the Veru. We'll park over the tip of the beak of the scope near the Veru, and then we'll see up.
So what I'll do is I'll play this video again if you can speak very slowly.
Yeah.
This is the Veru montanum here.
Yeah.
And directly above it will be this region.
Yeah.
But I've taken the incision little proximal to be on the safer side. I want to preserve as much mucosa as possible. So I take the initial incision ahead.
Yeah.
So that is one trick I've learned to for maximal preservation of the ventral mucosa. I take the incision a little further up than the 12 o'clock. Than the Veru montanum.
Yeah. And one more thing, Dheeraj. You don't see always the Verus will be single mound-like thing. Sometimes there will be diffuse Verus will be there.
Yes.
That time, what will be your correct landmark where you have to take? Because that Verus will not be like a single point. It will be a diffuse thing. Then, which will be the point where you take it as the center of that Veru?
That's the hard part actually. If you don't see the Veru properly, it's very hard to find the landmark. So as much proximal that 12 o'clock region as possible. Or sometimes you can develop the surgical capsule surgical plane posteriorly and raise the mucosal wings so that probably you can able to appreciate the concavity of the apical region.
So that will like gradual ascent technique, which Brazilian technique thing. So that from below we have to go up straight.
Below, if you go up, probably we can appreciate the concavity at the apical region, and probably I can take a mark. In which case we are not able to do the early apical release.
Yeah. So main take-home point here is that Veru, though we consider it as an anatomical landmark, it will not be same for all the type, and also the orientation of the glands will be different. So each time, each case will be different. So you have to be conscious.
Even the prostate morphology is different because some of the prostates end at the level of Veru, and more often than not, some prostates they extend beyond the Veru. And I've gone through the anatomy literature, and I've seen that even in the anterior region also there are prostates which go beyond the Veru at some level. So the morphology is completely different, and every case is different when you come look at the anatomy of enucleation.
So your energy is also 35 hertz and 1 joule.
I started with the 1.5 joule, but I feel that 1 joule, I'm able to extract more out of the machine in 1 joule.
That's my opinion also. Usually 1 joule and 30 hertz we keep. Initially we started with 1.5 joules and 33 hertz. But somehow there is a more of charging in the charring effect, and there is no clear-cut demarcation between the capsule and the adenoma. So when we reduce the energy, 1 joule 30 hertz, then there will be clear demarcation and we can do proper anatomical enucleation. And there are also some of the senior enucleation specialists like from Naeem Bojani sir. He does only with 0.5 joules and 30 hertz. Actually.
Yes,
0.5 joules. So, but we can't get that 0.5 joules energy in our IPG machines. So we have to, 1 joules is our lowest possible.
But there's a other trick where if we are not able to go beyond 1 joule, if we are not able to lower the energy further, we can fire the laser from a little behind. We can give a gap of 1 to 2 mm and we can fire the laser and much of the energy gets absorbed in water. That's how we can control the laser as well.
Yeah,
I'll show that in this video also, how to use the laser.
Yeah, good point, well taken.
So after giving this initial incision at the 12 o'clock region, what I'll do is I'll give mucosal incisions at either side of the prostate. If you can see here, I'm not touching the prostate because it might bleed. I'm firing the laser fiber away from the prostate. If you can see, when I fire, I'm already seeing the adenoma. If you can appreciate on the left side, the white color thing is the adenoma. I'm not touching it. If I touch it, it will char. So once I see the adenoma, I use the beak of the resectoscope and I'm gently trying to develop the surgical plane. Can you appreciate the white glistening layer here, the capsule?
Yes. Yes.
So
at this point, your hands will be at your scope will be directly perpendicular direction, right?
Yes. Another point here is how you identify the capsule is by looking at this prostatic calicula here, corpora amylacea, and also these vessels which are running parallel to the capsule. That's how you identify the plane. So once you identify the plane on one side, it's very easy to develop on the other side as well, because you know what level the capsule is. So you can develop easily the plane on the other side as well. You can, as you can notice, I'm not using any laser energy. I'm using only the mechanical energy. This won't cause any stretch on the sphincter because I'm doing it only in the posterior aspect, not on the anterior aspect. However, the dense tissue which is adherent to the verruca, I'll need to use this laser. The difference between contact and non-contact laser, if you use the contact laser, it's much faster. If you don't use the contact mode, it is slower. Just like in laparoscopy, when you're doing the important things, you don't touch the part because you want a clear anatomy. So this is developing of the posterior plane. This is real time. I have not fast forwarded it because the juniors will learn also. This is real time in which we can develop this plane. So this is the sphincter-saving technique which we are talking about. Previously, we have done it with the Thulium YAG laser. Now we are doing it with the TFL laser, the 35 watt TFL laser. As you can see, the inverted V-shaped incision I had given, and I'm deepening this incision. The idea here would be to find the anterior plane. Just like we developed the posterior plane, the idea here would be to find the anterior plane. I think this is the most important step in the anatomical enucleation of prostate. We spent some extra time here doing this procedure. This is the most hardest part. This is dividing the apical gland at the posterior aspect. This is the apical dissection at the posterior aspect. I'm not able to mechanically do this enucleate this apical region because I have very limited space. So I'm gently trying to use the laser energy and find some space. In one of the previous slides, I talked about the corner of the prostate. Yes. That corner, I'm not able to find it here. The beauty about enucleation, because I'm not able to find the corner in this case, what I have done is I've decided I will go to the other side. Normally, I'm a right-hander, so I find this doing the patient's left side lobe first easy. But in this case, it was a little bit different. So I thought I will try to enucleate the apical part of the left lobe. That is the beauty of enucleation. If you are stuck at one side of the surgery, if you're not able to find the right place, you come from the opposite side. That's the beauty of enucleation, which I like. If you can see it, this is the corner of the prostate. I found this anterior plane. If you can see, there's hardly any charring. This is the anterior aspect of the patient's right lobe. This is the corner which I'm talking about. If you can notice, I'm connecting the posterior plane and also the anterior plane. This is the corner of the prostate. Only if you are able to enucleate the corner of the prostate, that is a good sign that you are going to completely enucleate the tissue in an anatomical plane. Otherwise, you will have to use more of cutting through the prostate tissue. If you can see here, there is hardly any charring. I'm going on the capsule. The property is very similar to the holmium which we see. People say there is a lot of charring when we use the thulium YAG or the thulium fiber laser. It's how we use the laser energy. It's not charring is actually helpful. It will help us differentiate between the capsular plane and also the prostate gland which we see. So when we use the mechanical energy, we'll have to use this laser energy for controlling the bleeders or to cut any adhesions which is obstructing the prostate from getting peeled off. So once I got into the right plane, so you can see how nicely I'm able to mechanically enucleate the tissue. This dissection is being progressed from the verumontanum towards the bladder neck and from below to above in an ascending fashion. These are some of the adhesions which I'm trying to break with the laser. And if you can see, I'm not exactly in contact with the tissue. I'm firing it at a little distance from behind. This is an area where at the 11 o'clock region where we are very close to the bladder neck now. So I take this dissection towards the bladder neck till the 12 o'clock region. As you can see, the big vessels here, it indicates that we are very close to the bladder neck. Now I come back, I stop it at that point. I don't open the bladder neck. I come back and try to enucleate the lobe which we had a problem. Now that we have mobilized the patient's right lobe, we have a lot of space. Now this gland will fall towards the other side. Now I'll be able to find out the corner of the prostate, which I call it. Previously, I never had this space. Now, if you can see, I will be joining the anterior surgical plane and the posterior surgical plane of the patient's left lobe. This is the corner of the prostate. Can you appreciate that?
Yes, yes, yes.
That is a corner of the prostate, which I couldn't find previously. Now I found it because I've developed some space by enucleating the patient's right lobe. So this enucleation is progressing from the 6 o'clock to the 12 o'clock position in an ascending fashion. Now you can see a big vessel there. On the right side, you can notice in a short while a big vessel which is pulsating. These vessels, as you know, it runs parallel to the capsule. I actually find it very useful seeing these vessels because it will lead us to the right plane. If you can see here, I will use this big blood vessel as a landmark. Now on this side, unlike the other side, I've just tried to use more of laser energy just to show the difference. Previously on the other side, I used a lot of mechanical energy. Now I'm using the laser energy. As you can see, this blood vessels, huge vessel, pulsating vessel, I used as a landmark. It will guide to which direction I'll have to peel off this prostate. If you are in the right plane, I feel we can have a avascular plane in the prostate as well. Just like laparoscopy, you find avascular planes. I feel that if you can see, there are hardly any vessels. I hardly had to do any hemostasis. Right from the verumontanum till almost the bladder neck, I hardly found any blood vessels which I need to coagulate. This is the proper anatomy over the capsule through which we need to enucleate. After that, when we reach the anterior, we try to join the anterior plane on both the right lobe and the left lobe. This is breaking the anterior commissure. So once the anterior commissure is freed from the apical region, what I'll do is I'll connect both the left and the right planes anteriorly. If you can see here, this is the anterior plane from the right side. I've peeled it from the lateral side. So this will continue towards the opposite side as well. And I firmly believe that we need not do a 3-lobe technique or a 2-lobe technique because it's only we're giving more incisions. It's taking more time, and we can have an advantage of when we are facing any difficulty in finding the right surgical plane. We can come over from the opposite side and connect both the planes, find the nice planes. As you can see here, I'm hardly using any mechanical energy. I just use this just for a demonstration. I'm only using the TFL laser with 35 hertz and 1 joule. And I'm not even contacting the tissue as well. Just like I'm getting the Holmium effect, if you can see. And slowly, after joining these anterior planes, I'm progressing towards the bladder. This is the bladder entry. As soon as you see these vertical fibers, I don't jump into cutting the bladder. I try to develop a uniform plane both on the right side and the left side and cut the fibers slowly. Because cutting the fibers slowly, we can see all these, appreciate all these nice vessels, which you can, if at all there's a bleeding, you can immediately visualize it and take care of it. If you jump into opening the bladder initially, if there is a bleeding, it's very hard to control, especially in big glands. Now we can see that I've developed this bladder neck plane, and I've cut the bladder neck at this 12 o'clock region. And my next step would be to bring the lateral lobes down. Once I enter the bladder, you can see I'm not cutting the bladder neck. I like the bladder preservation protocol. I'm just cutting the bladder mucosa, if you can see. So once I cut this bladder mucosa, I try to separate this prostate off its capsule. Here I'm using a little bit of contact mode, but once at the bladder neck, the prostate is separate, then rest of the lateral lobe dissection, I'll do from the lateral to the medial. Again, you can see my non-contact mode coming into play, and it's just like peeling off the prostate off the capsule. You can also appreciate nicely the blood vessels there running parallelly over the capsule here. There's hardly any charging. This is the patient's right lobe after the left lobe is completely brought down from anterior to the posterior side. Then I'm coming from above downwards, bringing down the right patient's right lateral lobe. This is the final part of the bladder neck, prostate attachment at the bladder neck coming down. After that, the only thing we are left is the posterior dissection. People say that when we are especially doing this unblock, it's a little tricky when we are doing this procedure. But bringing down the lateral lobes from above downwards laterally gives you a landmark of the bladder neck. If you can notice here in a bit, you can use this bladder neck as a landmark here, and you can nicely lift the prostate tissue. Here also I'm not cutting much. We can always find the right surgical plane anywhere, not only in the anterior side, lateral side, also in the posterior aspect. If you are in the right plane, we can nicely use mechanical enucleation to nicely peel away the prostate from the bladder neck, from the capsule. This is the final part of the posterior dissection. This is the only area where, apart from the verumontanum, I use contact with the laser, contact energy with the laser. This is the only area where I turn my scope upside down. I put my laser fiber at the 12 o'clock position, or between the 11 o'clock and the 1 o'clock position, so that I can shield the prostate away from coming into the way. And I find that for beginners, this is the area where it tends to perforate more often. If you can see here, I perforated a little and I corrected myself by cutting the prostate rather than trying to find the perfect plane. And one more tip I can give you here is, in the final part of the enucleation of this posterior aspect, we should keep the bladder full. Because if you keep the bladder full, the ureteric orifices are usually well away, and also we can prevent the ureteric orifice injury as well. So this is the final part of the posterior dissection being complete. And if you can notice here, there is hardly any charring, because I have hardly used any contact mode of the laser. I've either done the mechanical enucleation. If you can see here, there's hardly any carbonization. The effect which we'll have from the holmium or from the bipolar enucleation, there is hardly anything, any difference here. There is hardly any carbonization. It's the way which we use the laser. It's very important. Using either the mechanical energy and coagulating with the laser energy, or applying the laser energy a little away from the plane of dissection, we get this kind of effect without any carbonization.
Excellent, Dheeraj.
So this is the end of the procedure. And this is the follow-up ultrasound, which we normal protocol would be that I remove the catheter within 1 day, 24 hours. I remove the catheter. I offer patients daycare procedure as well. If the patient wants to go home, if he's from nearby, I send the patient home, and next day he comes for the catheter removal.
This was the ultrasound done on what day, Dheeraj?
Sorry?
This follow-up ultrasound?
Yeah, follow-up ultrasound would be done in a week when he comes back. And this is not the uroflowmetry of this patient, but these are the kinds of flows which we achieve with doing this enucleation. If you can see here, the max flow here is about 49. It's almost like a super voider, and the average flow which we have achieved is about 22 in this patient. So these are the kind of uroflows which we achieve after enucleation, and I am a strong, firm believer of this enucleation rather than TRPs, even for medium size and small glands as well. And Manas, how do you want me to proceed? I have a video of this.
Can you just show me that the ultrasound gate and morcellation, please?
Morcellation, yes.
Yes.
So this is the ultrasound morcellation. If you can see here in this picture, this is a 300-gram prostate here.
Yes.
And his bladder capacity was very low.
Okay.
And there will be if you can see the bladder here, I'm hardly able to fill the bladder. And there will be occasions, like you said before, there will be bleeding and there will be hardly any vision. So if you can see this, I don't have better videos, but if you can see here, the bladder is full.
Yes.
And you can nicely see the ultrasound, and this is a morcelloscope here. And this is the prostate which is getting sucked out. And I don't have the vertical image. This is only the axial image. If there is an other transverse angle, you can appreciate the whether the probe is towards the anterior or the posterior side as well.
Yeah.
Yeah.
Continue. Disposable morcellate.
So other thing is always have one thing I learned from my father is that always have a backup, backup for everything. Because my program, enucleation program, started for about 6 months because there was a problem with the Wolf morcellator, and there was no proper service at that point of time. There were hardly any morcellators being used, and so I had to get this disposable morcellator. As you can see, one of my technicians is assembling the unit, and this is a rechargeable. The battery can be charged. There will be 2 batteries all the time.
Yeah.
There is no inbuilt suction, but we can use a suction which we get. And I use this 5 liter, not the regular 2 liter. I use this 5 liter so that especially when we are doing this big glands, we need to have this bigger suction units.
Do you think this disposable thing has the same capacity as the one which we use, Tall Stores or Wolf Piranha?
I've used all the 3. I find that this rotatable morcellators, if you can see this disposable thing also is a rotatable blade.
Yeah.
All these rotatable blades are good.
But somehow we don't have the good experience with this Quanta disposable thing. Actually, we had used it for a couple of months. Somehow we were not happy with that power and the morcellate speed, because a bit less, maybe, don't know.
Probably it is also because of the setting which we use, and the suction has to be very good.
Yes. We also get that some 3 types of speeds with this in this one, right?
Yes.
Low, medium, and large thing.
No, actually 7 we have. I'm showing this. So this is how we on the unit, and there are 7 different settings. This is 1, 2, 3, 4, 5, 6, 7. 7 different settings are there, and usually I'm very comfortable with the 3rd and the 4th level speed which we have. Yeah. So that is it, and I have 2 more videos actually if we have time, or I've used this Quanta 60 watt as well, which has similar properties. And
just you can show this.
Or
this fiber dust, right? Fiber dust.
Fiber dust. Yes.
Just you can just speedily run through the video so that you can see the difference between the TFL and this fiber dust also.
I find it almost the same actually. If you can see here, I'm using again.
We'll get the lowest. What will be the lowest energy we get with this?
I think it's pretty much the same. I'm not very sure. I just used it for the demo 2 months ago, but it's very similar to the IPG TFL which we normally use.
Yes. Okay, and about what about do you have any different patient position for this enucleation specific?
Enucleation, just like I showed in the previous slide, I've done enucleations for at least 4 or 5 patients who had rigid pelvis, where there was difficulty in putting them in lithotomy position. So I've used the Allen stirrups kind of stirrups where I can adjust it even when their patient is draped. And especially when we are doing these big glands, when we need these extreme hand movements,
Yeah.
proper
Yeah.
spacing has to be there.
Most extended lithotomy position do you ever tried for
Not for everybody, only for patients who have rigid pelvis.
large glands?
Not usually required the extended lithotomy.
Yes, chalo. Okay.
I managed till now. I managed.
Yeah, yeah. And how
So
about this your anticoagulant?
these are all the advanced Thuliums which we have done over a period of time. After doing at least 2 years of regular enucleations, then I, for all the juniors also, I recommend that before trying all these cases, we have to do the regular cases. All the 60 grams to 100 gram prostates are the ones which we'll have to initially try. And big prostates, usually there'll be orientation problems. We go into multiple planes, we end up in a lot of problems. And when we are trying to enucleate the small prostates also, it is possible, but it's only, I consider it to be done after quite some time. And I have a good experience with this hypotonic bladders. I have done at least 28 patients who have documented hypotonic bladders, and only 2 patients are on CIC right now, and most of the patients avoided. And we are coming up with some results for this enucleation of hypotonic bladders. And we have tried some enucleations for prostatic abscess. We have 8 patients who had active prostate abscess, and we were able to enucleate completely. And I found that vapor enucleation, which I described earlier, the use of lot of energy, is particularly useful in creating a channel very swiftly as well. And we have done simultaneous laser en bloc TURPs and simultaneous lithotripsies. And patients and anticoagulants, since I work in a different hospital in a different city, which is a cardiology-based hospital, they also have this laser, and many of their patients are on anticoagulants. And I think after gaining some experience, I'm not stopping ecosprin. I stopped the clopidogrel medication. I'm not stopping ecosprin.
Okay. How long? 7 days or 5 days? Clopidogrel.
Clopidogrel I stopped for 5 days. Ecosprin I don't need to stop now, but in the beginning stages, probably it's a good wise thing to stop. And
even 150 mg ecosprin you don't stop.
I convert it into 75 years. If it is a high-risk patient, probably I bridge them on Clexin and do them.
How early you restart those things?
Within the ecosprin same day. If at all I stop the ecosprin, it's on the same day. Clopidogrel after 5 days.
Clopidogrel after 5 days.
So
most of your catheter removal will be the second
24
day.
hours. 24 hours.
24 hours.
24 hours. Yeah. And if I think the urethra is very narrow, if I've shared the urethra a bit, probably I'll leave it for a longer time.
Maybe 3 days, 4 days.
Yeah, I'll ask the patient to go home very safely, and I'll ask them to come back at whatever convenience they have after 72 hours, probably.
Yeah, during one of our previous discussions, you told that you are planning for same day discharge, daycare surgeries.
I'm already doing it actually, daycare discharge, but I leave the catheter on. If at all, I give the option. The patient, if he stays in Vijayawada and around, they go same day. I will give them
with catheter, they go home
with the catheter. Because most of our surgeries, we start doing early morning surgeries. 6 o'clock we start our surgeries. So whenever we are doing this daycare procedures, we finish them by 10 o'clock. Evening we have a look. We make sure that without off irrigation there is no bleeding. Since we are able to completely enucleate the gland, I don't see any reason there will be any risk of bleeding.
You send the patient with catheter, then when they come back for catheter removal?
Next day morning they come back. We give them a warning trial next day morning.
Yes, very good. Then, and there is now about this stress urinary incontinence. How are your rates of stress incontinence as of now? Because since you are a senior in enucleation, so almost 3 years you have been continuously focusing. So previously in the initial stages, how was your stress incontinence rates, and now how do you really see there is anything different?
Yeah, I think the biggest challenge for doing enucleation is the thing of stress urinary incontinence. think initially when we started the program, the initial incontinence rate were as high as 20%. It almost made us to stop doing the procedure for a while. So only then we pursued this early apical release and the sphincter-saving technique, or doing the unblock technique, finding the right plane. Only then we were more confident. And right now, if you ask me, the incontinence rates are about 5 to 10% for the first 15 days. And I don't see any stress incontinence beyond 15 days. Very rarely I see. Probably I feel it's more because of the age or any previous neurological condition. I feel the stress incontinence rate has come down drastically. But I agree that there would be little stress incontinence whatsoever. However, whatever technique you master, I feel little bit of incontinence is expected, and I'll counsel the patients also regarding the same.
So in case if the patient does have the incontinence, so what will be your protocols for managing the incontinence?
Nothing. It's all about assurance. I'll start straight away counsel the patient after the surgery that when I remove the catheter, there will be some incontinence whatsoever, and that's the trick here is constant counseling to the patient and also giving them assurance. They'll be very comfortable. I don't give any bladder relaxants. I don't teach them any Kegels. Only if the incontinence extends beyond 6 weeks, which I was seeing previously, but off late, I'm not seeing any incontinence beyond 1 month or 6 weeks. I never had to do, I'm not using any bladder relaxants or the Kegel exercise off late.
Okay. There's no need of any grading of incontinence also. You don't grade also.
I'm collecting, because we are compiling data. We are collecting how many pads they are using per day, or if at all there is a good amount of incontinence, how many diapers they are having to change, only for the documentation purpose. But most of the patients, since we counsel them well ahead, they are very comfortable. They are hardly having any hard time explaining to the patients about it.
You regularly do that post enucleation PSA evaluations and everything.
Yeah, my follow-up at the end of 1 week would be checking the PSA and doing the Euroflow, and also doing the PVR. Now, these three would be a mandatory for me, along with the IPSS score. Now, because we are doing a randomized control trial of this Thulium YAG and the Thulium fiber laser, I hope soon the results will be out. And I'm trying to use the similar energy. And one side doing, some cases doing mechanical, some cases doing the laser energy. We'll come up with results very soon.
And did you notice while doing your TFL, you told that when you use more of the mechanical energy, you notice that there is amount of bleeding and clots. You have done on the right side, you have done the mechanical enucleation, the lateral part. And after doing some part of the lateral part, then you come to the opposite side on the left side and you start doing the enucleation. Again, when we go back to the previous side, then you see a lot of clots collecting there because of this mechanical energy. That can be usual. Most of the time will be prevented when you use less of the mechanical energy and more of the laser energy.
Yeah, that's a good observation. Actually, in this particular case, it was absolutely what the way you are told. It's a good observation. But yeah, we do more of mechanical. There's a chance that if you don't come back and coagulate the vessel, there will be bleeding. Probably if you are careful doing the mechanical part, and you come back and see the vessels and do the take care of the bleeding vessel, you won't have this problem. If you are go on with the mechanical and you don't address the bleeding, probably then you'll end up with some little clots there.
So we have seen most of the seniors also, like Professor Andrew Gross also. He also says that if I use the my enucleation time is about 90 minutes, then my laser time will be only 10 minutes only. The rest of the 80 minutes will be mechanical energy. Sir does very good also. Correct. But different people use different type of energy. At the end of the day, enucleation is enucleation.
Yes. It's how comfortable you are using with the laser energy, how comfortable you are with finding the right plane. I feel mechanical dissection, if I do, I'm able to find the plane nicely. If I'm touching the laser energy and or the prostate, everything gets charred and I'm not very happy with the surgical planes.
And one more thing about what is most of the whole guys, what they say is, TFL guys, you are doing more of charring because the field will be all brownish color. And also Professor Gross also says that this charring is like seeing a color TV and comparing it to the black and white TV. Whole will like is a black and white TV. Everything will be white.
Correct. Actually, that's an advantage. Having the charring is an advantage because you are able to appreciate nicely whenever you lose the plane. you are able to appreciate the difference between the capsule and the prostate. The prostate actually charges more, the capsule won't charge as much.
Whenever you're on the capsule, it will be like a white color. Whenever you're in the gland, it will be like a charge.
You can use it to an advantage in the training stage.
This TFL is like, it's like a boon for the new beginners, so that you can easily differentiate between capsule and this one. Whenever you go directly to the whole app and do some,
it will cut down the learning curve.
Yes.
Thulium lasers actually will cut down the learning curve.
Yes, many studies also that Dmitry Enucleation also shown that TFL definitely reduces the learning curve. Since it's our own experience, so we don't have any whole app experience. We are only TFL. We have done with only TFL. The TFL only initially we started off doing with the en bloc enucleation. So we haven't done directly 2 lobe or 3 lobe traditional technique. With en bloc only, we could, with after 20-30 cases, we are able to completely finish the case actually. So that it's our own experience, and saying that TFL definitely reduces the learning curve, and also en bloc enucleation also helps you to reduce the learning curve.
Yeah, that is a good takeaway point. Yes, and unblock also is very representable. I mean, you can learn the technique easily.
And we have our very good teachers like Fernando Gomez Sancha. He's like a teacher for all of our youngsters for en bloc enucleation.
A lot of videos on the YouTube which we can learn easily.
Yes, that is one of the very good like a library for all the new beginners, so that follow his videos, so that we can see what are the positives and negatives of the enucleation, not only with the Holmium, but there will be very good learning points from his videos. Everyone, I think he is like a universal teacher now. He has become like a universal enucleation teacher.
Correct.
Yes. Yes. Then any questions from the? Yes. Yes, Dheeraj, we have some questions from online.
Sure.
Just want to ask you about this vapor. Do you have any experience of about doing the enucleation after previously, which you had in the initial stages, you had done vapor resection, vaporization technique? Those patients have come after 1 or 2 years again to you with the reduced flow. There's the similar symptoms, and have you done any enucleation to those type of patients?
We had to do actually, at least I've done at least 3 of my own patients where I've done vapor enucleation. Patients were not very happy. And that was back in 2019-18, where I was not doing the entire thing. I was leaving a lot of tissue behind. Of late, when the patients come back, I was able to offer them this post-enucleation anatomical resection of the prostate also I was doing, and completely removing the lobes. And also I have a lot of patients where TURPs were done by my father also 20 years back, 15 years back. When they come back, probably when we are doing this enucleation, they're extremely happy.
How about the feasibility and how easy is it to find the plane in those?
You would be surprised that it is more easy. More easier because much of the vascularity is already taken care of in the first procedure. So the bleeding from the whatever residual prostate is there, it is very less. So if you are able to find the right planes, then there will be hardly any bleeding in this kind of procedures. You'll be surprised actually, if you develop the right plane, there will be hardly any bleeding, and the procedure is easy actually.
And one more question, actually it's a comment, it's from Bhargavardhan Reddy sir. Hi Dheeraj, excellent presentation. Which one you suggest, 35 watts or 60 watts TFL for the prostate?
It's a very difficult question for me to answer because I already came from learning curve already crossed before I had to use the 35 watt laser. I'm able to effectively use the machine. But for a beginner, I feel that having a continuous wave, having a higher watt energy is good, because if you are not able to complete the procedure, if you're not able to find the anatomical planes properly, probably you'll need to use the vapor enucleation effect of the higher wattage machine. Probably a 60 watt would be a good thing if you are trying to start enucleation, because if you're using that 35 watt laser, you are not able to develop a good plane. You will lose interest, you will take a lot of time, and the program will get upset for a while. Probably the higher energy machine, if you can get, I think that will be better.
Correct point. always have the higher energy. So need not that you use high power, you can use a lower power only. The same amount of energy which we get from the, for example, 30 watts energy from the 60 watts machine is different when we get the 30 watts energy from the 30 watts machine. Definitely there will be advantage, always have the higher watts energy with you. And one more, Purnananda sir is saying that is there any non-anatomical enucleation of the prostate? That's the question.
That is a vapor enucleation which we assured, use of more laser energy, and without going to the capsule, we can just follow the curvature of the prostate and try to enucleate it. It's good enough for the medium-sized glands, but when we are doing this enucleation, non-anatomical enucleation for the large glands, there's a chance that you might lose the planes. The orientation will be lost. They will open up multiple planes, and we'll end up with a lot of bleeding also from the same vessel at different sides, just like TURP. And I believe that the role of non-anatomical enucleation is over. I mean, we should be more sound with our knowledge of proper anatomy, and we should follow this anatomical enucleation of prostate. What are the energy sources? Be it holmium, be it thulium fiber, or even the bipolar enucleation. If you are in the right planes, the message which I would give is it's not only the energy source, it's how we develop the planes is also important.
One more congratulatory message from Sridhar Gangavarapu. Great presentation, Dheeraj.
Thank you.
So many congratulations for you, Dheeraj. For many audience have given you they're congratulating your presentation. Good job.
Thank you.
Yes. So that's it. Coming to the Dheeraj, can you stop your screen sharing, please? Just a minute. Just I have a small announcement. Okay? Yeah, and from Preeti Urology Kidney Hospital, as you all know, we are conducting this exclusively prostate enucleation, laser enucleation, mainly comparing the merits and demerits between HOLEP and the TUFLEP. So there is no Holmium YAG, only TFL and the HOLEP we are doing. It's on the September 11th in Hyderabad, and we are all having our esteemed faculty like seniors like Anil Vashti sir, Pankaj Maheshwari sir, Tanush Pal Bhatia sir, and Abhay Mahajan sir, and our own Dr. Chandramohan sir will be there, and our own Hyderabad's famous enucleation specialist like Vamsi Krishna sir, and also Dheeraj will be there, and Ashish Saini sir from New Delhi, and Arup Kumar Nath from Guwahati will be the main faculties for this workshop. And we all request everyone to participate in this one, and we can assure you that you will have the very good academic extravaganza about the prostate enucleation. It's a single day workshop. You can come in the morning and finish up and can go back in the night itself. It's on the Sunday. And we have planned for many presentations also. Presentations, and the main we are planning for about 4 HOLEP cases and about 4 TUFLEP cases, so that different people you can see the different types of laser energy for enucleation and different techniques like 2-lobe, 3-lobe, and en-bloc techniques. And then you can also see the different modulators in action also, and different laser energies, different holmium energies, 60 watts, 100 watts, MOSES, and everything. So I'll request everyone to make good use of this workshop. 31st July will be the early bird registration. So make good use of this workshop. Thank you. And once again, I'd like to thank Dheeraj for accepting our invitation and giving a wonderful presentation about TUFLEP and also Thulium YAG enucleation also. And we'll be looking forward to you, Dheeraj, for the workshop on the September.
Honestly, I take this opportunity to thank Dr. Chandramohan sir and the rest of the Pure Urology team for having me deliver this talk. Thank you. Thanks a lot.
Thank you. Thank you, friends. We'll meet in the next presentations. Thank you, Dheeraj.
Thank you.